Hello everyone. Today's presentation will be about tyrosine kinase inhibitors. We're going to start with some general background info and then we'll move on to the different drug targets and then further elaborate on each one of those and some clinical trials to go along with them. And then we'll have a brief overview of treatment so we can see a few of the tyrosine kinase inhibitors' roles in therapy, and then we'll finish up with a patient counseling section at the end. So the objectives that I have listed here are a good starting point when you begin to study. I'll try to emphasize the more important details throughout the presentation for you to focus on. But in general, hopefully by the end of the presentation, we'll be able to understand and explain the mechanism of action of TKIs, as well as identify the main TKIs and their primary indication. There are also 4 class-wide side effects that I feel are important to know, and also how to manage some of those side effects associated with the different TKIs. And then lastly, I feel it's important to be able to counsel the patients receiving them, including some unique counseling points, which we'll go over closer to the end. So I understand that once we get to the indications and treatment section, there may be some terminology that you have never heard of before or maybe not understand. So I've included this abbreviation slide to kind of refer back to if you were curious about some of the abbreviations we're going to be using later. So to start with, some background about tyrosine kinase inhibitors. The first TKI that came to market was imatinib. That was back in 2001. Some would consider imatinib to be really the grandfather of tyrosine kinase inhibitors. However, since then, many more tyrosine kinase inhibitors have been discovered and approved. As of 2017, kinase inhibitors altogether accounted for about a quarter of all the current drug discovery and research. And since imatinib's first approval in 2001, there have been over 10,000 patents filed for kinase inhibitors. And actually, that's just in the United States alone. So all that to say, TKIs are really a hot topic in research and in current cancer therapy. And because of that, there's some pretty substantial costs associated with these novel therapies. Average drug costs range between $6,000 to $12,000 per month. And these are drugs that really may be continued depending on the indication indefinitely. So a lifelong financial burden is something else to consider when thinking of these new therapies for our patients. So we're talking about tyrosine kinase inhibitors, but what exactly is tyrosine kinase? Well, the tyrosine kinase enzyme is a specific subset of enzymes whose function is simply to remove a phosphate group from ATP and then really just transfer that phosphate group to another molecule. More specifically, tyrosine kinases will transfer phosphate groups to tyrosine residues, which is where they get the name tyrosine kinase. The general function of most tyrosine kinases are to promote cell growth and division, while others lead to apoptosis of the cell. A good way to think about them is to compare them to really like on and off switches. So when activated, the cell is being told to grow and replicate, but in most circumstances, when turned off, the cell will remain dormant. To date, approximately 90 different tyrosine kinases have been identified, and many of the drugs currently available that target tyrosine kinases are really somewhat non-selective. That is, while the specific drug target may be something like EGFR kinase, the drug is likely to bind to other tyrosine kinases as well as the one it was intended to target. Some drugs are more selective than others, but we'll address that a little bit later in the presentation. So this image is a good picture of what the action of a normal tyrosine kinase is. Keep in mind that even though this diagram seems relatively complicated, there's actually much more going on than what is only depicted here. But for our learning purposes, this should suffice. So with a normally functioning tyrosine kinase, an extracellular ligand becomes bound to the extracellular kinase receptor. This in turn causes the migration of the kinase to form a dimer as depicted here. This then sets off a chain reaction of cell signaling structures and then ultimately leads to cell proliferation and growth in most cases. In tumor cells, this process becomes uncontrolled. So for the tumor cell, this process is good. However, for us, this process is bad. However, this does give us a location for drug targets. Specifically, our tyrosine kinase inhibitors, they work primarily intracellularly to stop this process from happening, therefore ultimately halting the uncontrolled cell growth and proliferation, and eventually leading to the demise of the tumor cell. So one concept that is not typically true of other chemotherapy regimens that has become more prevalent as our therapies become more and more targeted is the need for genetic testing. As you'll see later, the confirmation of certain genetic mutations may either qualify or preclude us from using certain tyrosine kinase inhibitors. Some advantages of TKIs are that they are small molecule, especially compared to like monoclonal antibodies that primarily bind outside of the cell. Though a small subset may bind extracellularly, the large majority will bind intracellularly. This also allows the TKIs to be given orally, which is a benefit for our patients versus other parenteral options like monoclonal antibodies that were previously used. Like I had alluded to earlier, some TKIs are quite specific in their target, while others seem to bind to many different tyrosine kinases. So let me real quick orient you to the charts I've made over the next few slides. But first let me say that I don't think it's necessary to memorize every drug, brand name, drug target, and all of the indications that I have listed on these next few slides. I do, however, think it's important to be able to identify at least some of the more commonly used tyrosine kinase inhibitors. So what I've done is I've bolded what I feel to be the ones you're more likely to see. So on the left side of the table, you'll find the primary target for each drug. And then on the right-hand side, the various FDA-approved indications are listed. I intend for the next few slides to be more of a supplement, so that if you needed a review of a certain tyrosine kinase inhibitor, you can look back on the charts, and they'll be there for you if you need them. The two main drugs on this slide specifically are imatinib, which we talked a little about earlier. We said it was the grandfather of the tyrosine kinase inhibitors, and it will most often be used in the treatment of Philadelphia chromosome positive CML, which we'll talk a little bit more about in just a minute. Additionally, erlotinib, which is an EGFR inhibitor, is a common treatment in patients with non-small cell lung cancer. So those are two of the ones that I'd really like you to focus on from this slide. Moving forward, this slide is what I'd like to call the melanoma slide, because these drugs are used almost exclusively in patients with melanoma with a specific genetic mutation. We'll actually review these classes of TKIs on a later slide, but in general, you can see that in terms of nomenclature, the BRAF inhibitors, all of the letters RAF in the middle of the name, all of those have those, and then the MEK inhibitors have NET, so that's something to look out for, kind of an easy way to realize which ones they're targeting. So on this slide, there's really just one drug that I feel is important to know, and that one is crizotinib. It's an ALK inhibitor, and it really should only be used in ALK-positive non-small cell lung cancer, so that's where its niche is. The other class of TKIs on this slide are the VEGFR inhibitors, and this is really one of the more non-selective groups of TKIs. I had somewhat mentioned that earlier, but this is a really good example of those. They really bind to several different tyrosine kinases, even though the primary target here for these various disease states is VEGFR. They really bind to several other targets as well. And then this is the last slide. This is really kind of like a hodgepodge slide. There are a lot of different targets here. Remember that there are around 90 different tyrosine kinases that we've identified so far to date, and really there's more being found each year, so I'm sure this list will grow. But the main one from this slide is to focus on the Bruton's kinase inhibitor, ibrutinib. This should be relatively easy to remember because it has Brut in the name of the drug. It's primarily used in our CLL patients. Again, when talking about these past three slides, try to focus on the drugs that I've emphasized, because I really don't feel like it's necessary to know all of the nuances associated with each drug. If you need to know them, you can always look back and refer back to those charts. So let's talk about some of the side effects of, just in general, a broad class of tyrosine kinase inhibitors. There's really four main side effects that are really important to know when it comes to TKIs. The first of the four is diarrhea. It's actually been reported in as high as 95% of patients receiving TKIs, and up to 25% of those patients that were receiving those TKIs experienced grade 3 diarrhea, which which is defined as an increase of, looks like 7 or more stools per day over baseline. So that's fairly substantial amount for those patients. The exact mechanism behind this is really, it's still kind of unclear, but it's thought to be either due to a direct cytotoxicity of the drug or some secretory mechanism involving the chloride secretion in the GI tract. The second of the 4 main side effects that I really want you to note is rash. This is most commonly found with TKIs that target EGFR. It makes sense because EGFR itself is widely expressed on our normal skin tissue, so hence why you get the skin rash. Specifically in patients receiving EGFR inhibitors, the likelihood of getting a rash is about 3 out of every 4 patients receiving those. And we'll actually talk about that a little bit more in detail in just a moment. So moving on to our third and fourth thing to remember in terms of side effects for TKIs, and they really go kind of hand in hand here. That's why I put them on the same slide. So drug interactions and hepatotoxicity. The TKIs are really notorious for causing hepatotoxicity simply because they're metabolized to the liver. So with that metabolism by CYP3A4, which is a common enzyme in our other drugs' metabolisms, it also gives rise to a large amount of drug interactions. So this is one of those classes of drugs where it's really important, if you notice it, to always check the drug interaction report if you notice you have a patient on one of these medications. So the next few slides that I've made are dedicated to really specific clinical pearls associated with drugs that target the different receptors. So this one's dedicated to the BCR-ABL inhibitors. So for those, some unique side effects that may occur seem to be more cardiogenic, such as MIs, heart failure, QT prolongation, and then also fluid retention. These drugs are really more commonly used in our CML patients when they have a specific mutation in their Philadelphia chromosome. So throughout school, I always tried to find interesting mnemonics or like random sayings to help me remember certain drugs or side effects. And so I made one up for the BCR-ABL inhibitors, and you can choose to use it or not. So the mnemonic is Prince of Bel-Air, and this can be used to remember a couple of things. So which drugs target the BCR-ABL gene, as well as what genetic mutation must be present. Because the Fresh Prince, was born and raised in West Philadelphia. And yes, I know Prince is spelled wrong, and the S, which is referring to the statin, is actually for its brand name, Sprycel. But for the other ones, like the P is associated with imatinib, the I is imatinib, N is nilotinib, the S, like I said, is Sprycel for the dasatinib, and then the B in Bel-Air is bosutinib. So hopefully that helps you a little bit to remember some of these drugs. So let's go ahead and move forward. So moving on to our EGFR inhibitors. These drugs are primarily used in non-small cell lung cancer, but this is where some more of the genetic testing becomes important for these patients. These patients must be EGFR positive in order to receive these medications. Another very important pearl about these TKIs is the rash that forms, which looks like sort of like acne. It's an acne-like rash. It's actually associated with an improved response to the drug. So a rash in these patients is actually a good thing. So there are some things we can do to prevent it, which is important to know going forward. And some of those things include counseling on sun exposure, so making sure our patients know to wear sunscreen. And if they're going to be exposed to the sun, make sure to wear long sleeve t-shirts and pants so that they can avoid that sun exposure, as well as using topical steroids, and then even in some cases, oral antibiotics. So occasionally, to go along with that rash, it may be a little too severe, and it may actually end up leading to drug dose reduction or even discontinuation. So some more data behind that rash. There was a retrospective trial that looked specifically at pancreatic cancer patients, and they compared gemcitabine with gemcitabine plus erlotinib. And so they found a direct correlation in these patients whenever they had the rash to their overall clinical response. So in patients specifically without the rash, about 1% responded to therapy. However, in those with grade 1 rash, the response rate increased to around 10%. And as the rash increased in severity, so did the response rate. And eventually it got up to about 13% as we went up to those grade 2 or above rashes. I've also included a picture of what the rash may look like. It may be a little blurry there, but as you see, it kind of resembles like an acne rash that we're all kind of familiar with. So now, let's move on to our BRAF and MEK inhibitors. I've included another mnemonic for these as well. Personally, growing up, I was not a big fan of vanilla Coke, so I thought it was appropriate for the mnemonic to be "Don't be vanilla Coke." So this is helpful because not only does it help you remember which drugs are used, it also helps you remember which drugs go together. So in melanoma treatment, only specific combination of BRAF and MEK inhibitors go together. So in each word of the mnemonic, you'll find the first letter of each pair of drugs, as well. So if you notice the don't, the D and the T are associated with the rapinib and trametinib. The B is binimetinib and encorafenib, and the vanilla Coke, the B and the C, is bimarafinib and cobimetinib. So other unique side effects of these drugs are the increased incidence of future malignancies that may form, specifically squamous and basal cell carcinoma. And the risk in these patients may be actually as high as 22%. So 1 in 5 patients may experience a future squamous or basal cell carcinoma if they've received these medications. So for this slide, I've included both the ALK inhibitors and the VEGFR inhibitors. For drugs that target ALK specifically, the risk of hepatotoxicity and QT prolongation is higher than our other TKIs. Unfortunately, these drugs are only used in a smaller subset of patients. When non-small cell lung cancer is only about 5% of those have that ALK translocation. For the VEGFR inhibitors, this is a class that's relatively non-selective for their intended target. So they have been used in cancers where traditional chemo has been found to be not very helpful, such as like hepatocellular, renal, and also thyroid cancers. So the next few slides are really more supplemental, but I want to introduce you to a few different cancers and show you where these drugs have found their place in current therapy. By the time that you're all listening to this presentation, the guidelines may have even changed. The NCCN guidelines tend to be quite proactive with their updates and changes to therapy as new drugs come to market. But for now, this is the most current. So for CML patients with specifically this Philadelphia translocation, the first-line treatments are drugs that target the BCR-ABL gene. This cartoon on the bottom here also does a decent job of depicting what is actually happening with the translocation. So once the translocation has occurred, the cell on or on-off switch is basically stuck in the on position, causing that uncontrolled cell division. So next, I've got a little slide on the melanoma patients. More specifically, TKIs become an option in melanoma patients with either stage 3, metastatic, or unresectable disease, in addition to that BRAF V600 mutation. So this is where our combo BRAF plus MEK inhibitors are being used in current therapy that we had talked about a little bit earlier. And lastly, the TKIs are a large part of the non-small cell lung cancer treatment. And as you can see here, there are a variety of genetic mutations that may occur and should be tested for. And I've included the various options for these patients if the corresponding mutation was found. So at this point, I really wanted to reemphasize that this would obviously be quite difficult to memorize. So I don't really expect you to know every detail over these last few slides. I simply just wanted to introduce you all to a few disease states where TKIs are being utilized, really at the forefront of cancer management. So please don't try to memorize everything on these last few slides. And as a reminder, here's Michael Scott telling you to stay calm. So the remainder of the presentation is really dedicated to more patient counseling. Really a huge intervention that we can make as pharmacists is making sure that our patients are aware of how to take the medications. It seems simple, but it's really important, specifically whether or not they should eat with them or if they should take them on an empty stomach. This small intervention can affect the overall exposure to the drug up to 200%, which is quite substantial. Again, this is not a chart to memorize, but just more as a reference to look back on later if you need it. So there are a few unique counseling points for patients that are taking TKIs. I've highlighted really 5 things that we as pharmacists can be sure to tell our patients. The first, and honestly the most important, is adherence. So some of the regimens associated with TKIs can be somewhat complex compared to your normal once daily dosing of other medications. So some regimens require therapy, for a few weeks, once daily, then they'll stop for a week and then get back on it for a couple weeks and so on. So it can be a little bit more complex. So it's really worth the extra time to make sure our patients know exactly how and when to take their meds. Because having an oral therapy is an advantage in regard to not having to take parenteral therapy, but at the same time, a disadvantage because we can't ensure that our patients take their doses 100% of the time. Specifically in the literature, compliance to TKIs range from 46 to 100% depending on what study you look at. And really missing just a few doses can ultimately lead to treatment failure. So that's really important to make sure our patients know to take their meds and how to take them. So next are drug and food interactions. This is something that may need to be looked up for patients, but it's really important to do so. Statistically speaking, approximately 4% of deaths in all cancer patients are due to drug interactions. So this is really an important intervention that we can make. And our patients also need to know how to handle the meds. And if there are any leftover medications for whatever reason, they need to make sure to know how to dispose of them. A good reference would be the NIOSH list to determine the specific hazard potential for the whatever specific TKI you're dispensing, as well as a package insert in the preparation and administration section. Also, it's important for patients that miss their dose, if it's within 6 hours of the normal dosing time, to go ahead and tell them to take their missed dose. However, if it is more than 6 hours, or if vomiting had occurred, go ahead and skip that dose and then resume at the next appropriate dosing time. And finally, the side effect management. We've already talked about various side effects for different TKIs, and it's always important to be realistic with our patients, as they need to know really what to expect from their regimen that they're receiving, so that mostly that they can monitor for themselves to watch out for those side effects that may occur once they get home. So in summary, TKIs are small, highly bioavailable molecules. They work primarily intracellularly to inhibit cell signaling pathways. There are several tyrosine kinase targets out there, including some of the more common targets such as BCR-ABL, EGFR, ALK, and Bruton's kinase. The 4 main class-wide side effects that I had mentioned to watch out for are diarrhea, rash, drug interactions, and then hepatotoxicity. And then recognition and management of those side effects, along with others that we've mentioned along the presentation, is one way for us as pharmacists to really be involved in the healthcare team. And lastly, direct patient counseling is another great way that we can directly influence the success of our patients' therapy and really their overall safety. So here are my reference here for you. Thanks a lot for listening in.